I'm going to get started. Nobody's told me not to, so I'm going to get started. I took off my name badge for this microphone doodad I'm wearing, but I'm Joshua Loeb. I'm a pediatric neurologist and epileptologist over at Loma, and I'm the co-director of the epilepsy division at Loma. Were you going to I'll introduce you. That's Tanya. She's with Synovian, and she was going to introduce me. A little role reversal there. I've been at Loma for 4 years. As I said, I'm the co-director of the epilepsy division and the medical director of our complex epilepsy team center. This afternoon, morning, wherever we're at, I'm going to talk about the basics of what we call medically refractory epilepsy. All right, they kind of send me an email and give me my choice of what I want to talk about. And this is kind of my favorite thing to talk about because I don't like starting off with, well, this is a small niche group for neuromodulation where I don't know if the audience knows everything that leads up to that discussion. I like to make sure, and I do this with my patients in the clinic, I give basically the same spiel I'm about to give you guys. I like to make sure that we're all on the same page, that we all have the same foundation, so that when we go to these other lectures and hear these other professionals talk, that we all have the same basic understanding of the disease that we're talking about. So we're going to talk about the world of medically refractory epilepsy. It's not going to take 50 minutes. I'm going to leave plenty of time for questions, so please keep those in your mind as I'm talking. So we start off at the very beginning. I think we all have a good understanding of what a seizure is and what our child's seizures look like. But I'm surprised at how many people have never been diagnosed with epilepsy despite their children being treated for years with seizure medications. So I start there. And what is epilepsy? Epilepsy is basically somebody who's had more than one seizure. That is the simplest definition. Somebody who has more than one seizure separated at least 1 day apart, they have epilepsy. It in and of itself is not a doom and gloom prognosis that means you're going to have seizures the rest of your life or you're going to have this, that, or the other side effect of the epilepsy. It just means that you've had more seizures, more than one seizure. And in the great big world of epilepsy, it all basically boils down to two seizure types. And our treatments can change depending on what seizure type you have. There are seizures that come from the entire brain at once, called generalized seizures. There are seizures that come from one part of the brain, could be any part of the brain, and these are called focal seizures. So one of my major jobs is to try to figure out whether the seizure is coming from the whole brain at once or one part of the brain, because that can direct some therapies down the line. For somebody who has had a single seizure, their likelihood of having a second seizure is about 50%. For somebody who's had more than one seizure, for somebody who has a second seizure, their likelihood of having a third seizure is about 80%. And so that's when we diagnose epilepsy. For somebody with epilepsy who we start on medication, the likelihood of the medication causing them seizure freedom is actually only around 50%. So half of the people with epilepsy we start on medications will be seizure free. If we add a second medication, because they're not seizure free, the likelihood that they're going to be seizure free in total is about 65%. So the second medication adds about another 15%, which means about 2/3 of people are controlled with medications and about 1/3 of people are uncontrolled, okay, on two medications. After the second medication, the likelihood that a third or fourth or seventh or ninth or 12th medication is going to result in seizure freedom is less than 5%. Okay? So once we hit that third medication, that's when we start using the term medically refractory epilepsy. And what that means is somebody who has a very low likelihood of becoming seizure free on medications alone. Okay? And it's because of this, it's because we've reached that threshold that we do start looking at other treatment options, okay? There are basically 4 ways that we can treat medically refractory epilepsy, 4 large categories. One continues to be medications, all right? Just because we're not seizure free on 2 medications doesn't mean that we go, medications are out, I give up, all right? There's still a lot of good that we can do on medications. Going from 100 seizures per day to 3 seizures per day, it's not seizure freedom, but it's life-changing for families. Going from 3 seizures a month that result in ER visits to a seizure every 2 months that result in ER visits. It's not seizure freedom, but it's still life-changing for the kid and for the family. So medications continues to be an option, and we continue to try new medications with the understanding that the likelihood of seizure freedom is very low. Okay. Another treatment option is epilepsy surgery, and I know that a couple other, I think one of our neighbor talks right now is about epilepsy surgery. And this is why it's very important that we know whether seizures are coming from the whole brain at once or from one part of the brain, because the basis of epilepsy surgery is if we know where the seizures are coming from and it's safe to remove that part of the brain, we could potentially cure your epilepsy. All right? And that's just how, that's the entire framework of epilepsy surgery. It doesn't work for generalized epilepsy. We know that it's coming from the whole brain at once. We cannot remove the whole brain at once. Resective surgery is not an option. But if we know that the seizures are coming from, say, the temporal lobe, and it's not where our memory is, it's not where our language is stored, we could safely remove it. There might be up to an 80% chance of curing the epilepsy. This obviously has significant lifelong implications, ability to drive, ability to hold a job, ability to live independently, things like this. So it can be life-changing for a lot of families, but it's not for everybody, and it can't be performed on everybody. But that's one of the major things that an epileptologist looks into. So you've got medications, you've got surgery. Okay, now a couple other things about surgery is that it's invasive, all right? Nobody's discounting the fact that we are talking about brain surgery, all right? Usually the first steps of epilepsy surgery are simple tests that you've probably undergone numerous times before, MRIs, EEGs, neuropsych testing, maybe a PET scan, maybe a SPECT scan, but by and large uninvasive. And that might tell us that the seizures are coming from, say, this area of the brain, right? Well, nobody wants to have brain surgery on the idea of, I think it's coming from somewhere over here. All right, that's a really big hand wave right there. That's a lot of brain. So the next thing we typically do is what's called intracranial monitoring. All right, where depending on the belief of where the seizures are coming from, we might remove part of the skull and lay some electrodes directly onto the brain, which is called grids or strips, and we monitor we put the skull back on, we bring you up into our epilepsy monitoring unit, we monitor, we wait for somebody to have a seizure, and that can tell us, instead of it's coming from this area of the brain, we can say it's coming from electrode 19, and it travels from 19 to 27, and when it hits 27, that's when we start to see the actual head turning to the side seizure activity. But it's actually right over here. And then we can use that grid also to stimulate different areas of the brain and say, okay, well, the seizure is coming from here, but language is way back here. So we have a nice margin around which we can do surgery without affecting language. So we can map different parts of the brain. Same with motor function. We can map that part of the brain. The other type of intracranial monitoring that we sometimes do is what's called depth electrodes, where instead of doing the craniotomy and laying electrodes directly on the surface of the brain, we put the electrodes directly into the brain, kind of like pin needles, all right, and it measures from there. I say it gives kids the Hellraiser effect, because on the X-ray or CT scan that we do afterwards, it just kind of looks like Pinhead from the Hellraiser movies. And that's the same thing. We monitor and we try to say, okay, well, the seizures are coming from, now we know that the seizures are coming from this area of the brain, and then we can do further testing if we need to determine if it's safe to remove. Depending on what type of epilepsy you have, surgery success rate, and we quote differently based off of what type of epilepsy and what the MRI imaging shows, somewhere between 40 to 90% chance of seizure freedom. Nothing's a slam dunk in what we do. But when you're looking at less than 5% chance of seizure freedom for medications versus 40% chance of never having a seizure and possibly even getting off medications, that can sometimes be very appealing to the family, even though we all know this is invasive and scary. All right, so those are two treatment options: medications, epilepsy surgery. Okay, a third treatment option is called diet therapy, most commonly the ketogenic diet, okay? The ketogenic diet is a very, very high fat, low protein, minimal carbohydrate diet. It's typically done in epilepsy centers with the help of dietitians, nurse practitioners, requires careful monitoring. This isn't the bikini weather ketogenic diet that is the new popular fad, all right? It is very different. It is very regimented, and we always recommend that we do it with the help of medical care professionals. And people often ask me what I think of the ketogenic diet as the new weight loss trend. One of the hallmarks of when we initiate the ketogenic diet is that we keep the kids' weights the same. The basic understanding of how the ketogenic diet works is we deprive the brain of glucose and we switch it to ketones, and the brain enters a starvation state, which we want. We do not want the child to enter a starvation state and wither away. So we actually stop the ketogenic diet if children are losing weight. So the fact that people are using it for weight loss just tells me that they're starving themselves. I mean, the ketogenic diet as a bikini weather fad, it's starvation. And that's all fine and good if you want to look good, but don't confuse it with the ketogenic diet that we use to treat epilepsy, because we take that very seriously. It comes with its own risks, its own side effects. We need to monitor those. We need to make sure your children are safe. So with the ketogenic diet, there's about a 40% chance of significant seizure reduction, about a 40% chance of some seizure reduction, and about a 20% chance that it doesn't affect the seizures at all, okay? Along with the litany of side effects you can have with it, constipation, delayed growth. One of the bigger concerns that we see is decreased bone density. There are also some positives that we often see outside of epilepsy. We do have a lot of families report that their children seem more alert, more interactive, and sometimes it doesn't touch the seizures at all, but the family thinks the child's looking and interacting so much better that they want to continue the therapy, and that in and of itself can be very nice to see. There are other types of diet therapies. There's the modified Atkins, which was popular about 10 years ago. The Miami Beach diet, I think they called it, which is basically a less restrictive ketogenic diet. And there's the low glycemic index and a couple other diet therapies that we use, but ketogenic diet's the most classic. So you've got medications, epilepsy surgery, and diet therapy. And then the last therapy that we typically investigate is the broad category is neuromodulation. And in children, the most common device that we use is the vagal nerve stimulator, so the VNS, all right? This is an implantable device. A battery/computer goes into the chest wall under the skin, wire goes up, wraps around the nerve in the neck called the vagus nerve. It sends a regular pulse of electricity. So it might be on for 30 seconds, duk, 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 duk for 30 seconds, and then off for 5 minutes. On for 30 seconds, off for 5 minutes. We can program this in the clinic. We have no idea why it works, but in about a third of people, there's significant seizure reduction. A third of people, there's some seizure reduction. About a third of people, it doesn't do much at all, okay? That's the most commonly used neuromodulator, the vagal nerve stimulator. Most common side effects is sometimes when it goes on, you get a hoarse voice, so the child may be talking, and then for 30 seconds they may talk like this, and then it goes off and they talk like this. This one typically doesn't cause significant distress. Families usually tolerate it and just move on with their lives, and it happens. The one that really drives families nuts is sometimes because the vagus nerve is also what triggers your cough reflex. Every 5 minutes, the child starts coughing. And so we typically monitor them in the clinic for a little bit after we turn it on, just to make sure they're not having that cough reflex, because that can be miserable to go home with. You go home and every 5 minutes you start coughing for 30 seconds and then stop. We don't want to send you home with that. Other types of neuromodulation, so vagal nerve stimulator is approved 7 years and up, is that right? 4. All right, we're now 4 years and up. There is the RNS, the responsive nerve stimulator. As I said, the hallmark of epilepsy surgery is people who have a single seizure location that's safe to treat or safe to remove. The RNS is used for people who either have more than one seizure location, so we're not just going to start Swiss cheesing your brain, take a little from this side, take a little bit from back here, and hope that we carve out enough to leave a seizure-free person at the end. That's not good treatment. But the RNS allows us to implant electrodes directly into the different areas of seizure onset. So if we know one's coming from here and one's coming from here, we can implant electrodes in these two places. It actually monitors your brain waves, and at the beginning of you train the computer program to recognize as a seizure, then it sends the electrical signal to abort the seizure. Okay? That is only 18 and up at this time, although they are petitioning for a lower age. And then most recently approved is the deep brain stimulator, which is electrodes that go into the brain, into the anterior nucleus of the thalamus. Fascinating information, I know. And this sends a regular electrical signal. This one was the most recently approved device, and I believe it's 14 years and up. I have not done this on any child at this time. So those are your 4 treatment choices: your medications, your epilepsy surgery, your diet therapy, and your neuromodulation. And I not very frequently, but I occasionally have people who come in who haven't tried medications or have tried one medication and either had bad side effects and stopped it or it didn't work. And they immediately ask me, well, I don't want to put my child on medications. Can I do the ketogenic diet? And the reason I kind of explain these numbers is so that I could then explain no. I can't do that, because when I look at the numbers and I look at first 2 medications having a 65% chance of seizure freedom versus the diet that has a 40% chance of significant seizure reduction, medication wins out drastically. No matter your thoughts on big pharma and the evils of big pharma, or whatever the hang up happens to be on big pharma, the numbers speak for medical management as the first 2 treatment choices. Now you failed 2 medications, now you're talking about less than 5% chance of seizure freedom versus 40% chance of seizure reduction. Absolutely. Love the ketogenic diet. Run the ketogenic diet clinic. Vagal nerve stimulator, absolutely. But that's kind of why we always start off with medications, because the numbers just speak better towards medications at the beginning. Coming off medications is another frequent question I get. The goal, sorry, I'm sucking on a cough drop and it's migrating through my mouth while I talk to you. Let me stick that back into my cheek. You get that? All right, good. When to stop medications? The kind of party line is 2 years seizure-free. All right. It's usually the first question I get asked after I tell a family I'm putting them on medications. Is when can I stop the medications? 2 years seizure-free. If you had a normal EEG, a normal MRI, and no seizures for 2 years, you have an 80% chance of staying seizure-free after 2 years versus a 50% chance if I stopped you after 1 year. If you have an abnormal MRI, an abnormal EEG, it's about a 50-50 chance, but I always give the families the option. Even if I have the strongest feeling that seizures are going to come back, they were so difficult to control, it took very high doses of multiple medications to stop the seizures, I give everybody the chance to come off of it. I have no problem with that. We can get the seizure control back, but I give everybody the chance who has gone 2 years without a seizure. Now, if we go 2 years without a seizure and I take medications off and the seizures come back, I don't necessarily retry it every 2 years. Most families don't want to retry it every 2 years. All right? That's basically the spiel that I give to all families who come and see me for a new consultation for refractory epilepsy. And I think that gives us the most solid foundation to then delve really in depth on any one therapy or another. And so at this point, I do want to open up, I think I breezed through that relatively quickly. I do want to open it up to questions that I can hopefully answer for you about any of these topics.
So my niece is 2.5. She just got her, I want to say it's a 72-hour EEG, and the hips arrhythmia is gone. from what my understanding is.
Good.
How would you wean off of? Would you wean off of Sabril, or would you transition to a new medication? How would that work so that we can prevent? Because I know that my brother-in-law is concerned about it, and my sister is concerned about it turning into epileptic spasms versus the infantile spasm. So how can we control that with medication, or should we just continue with the Sabril?
I would not change the medication unless they've been seizure-free for 2 years and we're talking about discontinuing it. I know there are concerns about some of the side effects of Sabril. The big concern with Sabril is peripheral vision loss, which is from here to here. Never been proven to be clinically significant. And so if I have 100% seizure control, I'm not touching anything till the 2-year mark.
Okay.
It's just, especially with infantile spasms, which old terminology was called a catastrophic epilepsy. I don't touch a good thing if I don't have to.
Okay.
Yeah.
Hi.
Hi.
I'm Holly.
Nice to meet you.
I am the sibling and also the caregiver of my sister with Lennox-Gastaut syndrome.
Okay.
She's been diagnosed now for 29 years with the disease. She had her first seizure when she was 7 and was diagnosed with regular epilepsy for the first 22 years of her condition.
Mm-hmm.
And then finally saw an epileptologist, and they said, no, you have Lennox-Gastaut syndrome family. This is why she has this very rare catastrophic disease, and it's untreatable. So I'm here to find out if you've already done the ketogenic diet, if you've already had a corpus callosum hemispheric split, 2/3 of the brain,
Mm-hmm.
if you've already had the implant for the VNS through Cybernetics, and you're open to trying anything because you've seen your sister life-flighted 7 times. What do you do at that point? Would somebody like that qualify for the deep wave?
The DBS?
Yes.
I believe so. I'm not as familiar with the DBS because it's new and we just haven't had any need to do it in children. So I don't know if it's FDA approved for generalized epilepsy or if it's focal epilepsy only. That would be my only hang-up. See, I'm pediatric neurology. I go off-label all the time, so it matters less to me whether they're generalized or focal. For the RNS, the VNS is approved for focal epilepsy. I use it for generalized, and it works great. I would assume similar for DBS, but I think that would be a reasonable thing to look into. If you've already done corpus callosotomy, you've already done vagal nerve stimulator, that's kind of one of your last non-traditional medication. That's one of your few devices left to try. And I don't believe that a VNS is a contraindication for a DBS.
Okay.
Yeah. But seeing as it's relatively new, it might be hard to find a provider who's knowledgeable and comfortable with it.
So the RNS device, I have a 17-year-old daughter who's had epilepsy since we figured it out at 8 years old. Mostly she has small-ish, 2 to 5 minute seizures that are smacking of lips and sort of, unfortunately, typical seizures, moving of arms.
Mm-hmm.
And she's had a few major seizures as well with hospitalization. She has a VNS device. She's on 2 meds. She's failed probably 8 to 10 meds. The recommendation 2 years ago was for an RNS device, but because of the issues with FDA and not being approved for under 18, and also wouldn't be able to have an MRI. I guess the device is MRI-able, but the FDA didn't approve it, so we wouldn't be able to look at what's going on. For her, we know she has a lesion in her temporal lobe. So my question, and we decided, also she needed 3 leads in, not 2, and presently the RNS is only a 2 lead. So we decided to wait. Do you see the FDA approving this for younger ages anytime soon? And they also open up the MRI piece
cannot speak to the latter. I cannot speak to whether it will be deemed MRI compatible. I don't know how long VNS was on the market before they finally let people start doing MRIs for VNSs, and we know that we can do MRIs for VNSs. I know they have petitioned the FDA for a younger approval age. I was talking to NeuroPace yesterday. With a recent government shutdown, the FDA process got delayed because obviously the FDA is part of the government. So we're still waiting to hear back whether it's approved for lower age. I've got maybe 3 or 4 patients, children with multifocal epilepsy who would benefit from a lower age. And then I don't know enough to say whether or not your child would be a surgery candidate, but
And then just a follow-up question. I've been looking into stem cell research and sort of regeneration of parts of brain. Is there anything that you know about that kind of research, and is that something that's being pursued?
I know that there are institutions that are looking into it, and I would not trust any institution that says they can do it. And I've seen it for every neurologic condition in existence. I've seen it for drowning, I've seen it for spine injury, I've seen it for epilepsy, and I've seen parents shell out tens of thousands of dollars for something that has, trust me, if it was proven effective, we would all love to use it. There's no benefit in us for your children having seizures. There's no effective stem cell therapy at this time. And anybody who tells you that they've gotten effective stem cell therapy is very interested in something other than your child's well-being.
In your professional opinion, is there any hope for that in the future?
Yeah, I think I love that they're investigating it. I don't know whether we're talking about 10 years or 50 years. I think we'll be regrowing all sorts of things in the future, but I don't think I honestly don't think it's a near horizon. Based off of the meetings I go to, it's not. We've got a trial. We've got a result of a trial coming out next year. Stay tuned. We can't wait to tell you. It's still all. Well, we have some rats in a cage that we're waiting to see what happens. I mean, I would assume a couple decades away.
He just recently got a VNS in July.
Mm-hmm.
You can't get an MRI with a VNS, or I'm not familiar, I'm fresh, what is that?
The RNS, the responsive nerve stimulator, that gets implanted into the skull. Yeah, so VNS you can with the right type of MRI machine.
Okay, got it.
Yes.
Thank you.
Can you speak of drug holidays with patients, and does that ever give you a clue as to what may work? You have a 2-week, 3-week holiday when you start a new drug, and get the hope that all
Oh, you're talking about the honeymoon period. Okay. Drug holiday is when you take somebody off a medication. And we do that for ADHD over summer break. Sure, take them off, give them a break, put them back on it when school starts. I don't do that for epilepsy. You're talking about the honeymoon phase, which is this poorly described phenomenon, but we all know about it, where you start a new medication and for 2 to 3 weeks it works great, and then it doesn't, and you're back to your baseline seizure frequency. I don't know of any scientific explanation for why it happens. And sometimes it says, okay, well, he got some response, so maybe if we push the drug higher, we'll get a more prolonged response. And then I have some people who have been on 8, 10, 12 medications, and they have a honeymoon phase to every single one, and they all revert back to their baseline seizure frequency. And I don't think it provides the information that we hope it does. We all like to believe that, okay, well, you can get better seizure control then with a higher dose, but that hasn't been my clinical experience. So. Can epilepsy drugs cause epilepsy? I'm going to nitpick wording. Epilepsy drugs can't cause epilepsy because that's the inherent ability for the brain to seize. There are some epilepsy drugs that can worsen seizures. The most common example of this is your seizures that are used to treat focal seizures, especially your sodium channel drugs. I'm talking about your trileptal, your Dilantin. If you use those medications on people with generalized epilepsy, it can make generalized epilepsy a lot worse. So I've actually had patients where we've been able to diagnose generalized epilepsy because they transfer from their last doctor and they come to me and saying, oh, well, he put him on this medication and my seizures got so much worse and they're happening every day, so I don't want to see that doctor anymore. So they come to see me, I'm like, oh, well, that actually gives me a lot of information. That's probably a generalized epilepsy and might fall into one of these genetic conditions. There are a couple others where every couple weeks I get a phone call, I start a medication and the seizures worsen and the parents want to stop it. And I'm usually pretty agreeable with that, but I think most often that just happens to do with the natural fluctuation of seizure frequency, and you just happen to hit a bad week at the same time you start a medication. But certainly there are some trileptal Dilantin used in generalized epilepsies that do worsen them. But those would be the big two. I'm sorry, I answered your question? Okay.
How often do you recommend getting EEGs done? I have a little boy who's 6, diagnosed maybe about a little over a year ago, started on Keppra, and then he was doing fine. He wasn't having any seizures or anything like that. And then we kind of noticed that he was having like an increased thinking, and so we kind of told the doctor, no, we just see little tiny things, not seizures, but we just see little oddities, whatever. Can we do another one? I have an approval for it. Let's just do it. So we did it, and then she was kind of like not really wanting to do it, but she was like, we'll just do it anyways, that's fine. So we did the EEG, and then she called us back, and she's like, well, he's still having a lot of brain activity, so why don't we go ahead and get another medication on board? So then we started with the valproic acid. So I guess it's kind of like, even though he's not having the seizures, how do we know the medication's really doing its job if we're not having these EEGs done, and how often do you recommend getting them done?
Okay. There was a lot of really good information in that question. I'm going to try to make sure that I want to make sure that I hit as many of the points as possible. So I'm going to ask you if I answered all your questions at the end. With very few exceptions, the goal of epilepsy medications is to stop seizures. All right? Our goal is seizure freedom. Our goal is not to normalize an EEG. That is a fallacy, and you're just going to make somebody sick as stink pouring medications on top of them to make that the last of the epileptiform discharges disappear. Like I said, there's rare exceptions. Hips arrhythmia would be one of them. That is one of the epilepsies where you need to normalize the background. ESCS or CSWS is Orlando Kleffner. That's the other one. Those are the only two epilepsies where we need to normalize the background. Okay? So I only do EEGs if it's going to change my management. And so I probably do them less than most other providers, because if it's not going to inform me in some way, I'm just going to chase my tail, and I risk, I don't know if over-treating is even the right word, unnecessarily treating things that I shouldn't. So if somebody has epilepsy, I do an EEG, I know that yes, it's consistent with seizures, or I know it's focal epilepsy, or I know, and I have the information I need, and I start them on a medication, and they're seizure-free for a year, and a year later their seizures come back and they look exactly the same, a repeat EEG is not going to give me more information. So treat what we already know. Now if I have somebody who's been either seizure-free or not, and they develop a new episode type, say funny eye blinking episodes that happen 10 times a day, sure, I can hook them up to EEG for a day or two, capture those episodes, and be able to definitively say those eye blinking episodes are or are not seizures. And that's going to inform my treatment, because I don't want to add a second, a third, a fourth medication to treat eye blinking episodes if it just has something to do with the child's developmental baseline. That's just something odd that they do, and I'm making them now sick on their fourth seizure medication when it wasn't seizures to begin with. So if it's going to inform my treatment, then yes. But I don't do an EEG every 6 months. I don't do an EEG every year. I can do an EEG on somebody when they're 2 and not need to do it again until they've outgrown my clinic and they're with adults. Because if all the seizures are the same, the other time is An EEG when you first develop epilepsy is fine if you're, oh, I'm not really sure if these are seizures. Okay, there's discharges, these are seizures. And that's all I need to answer. Well, now that you've failed 2 medications, now I'm asking a different question. Now I'm asking, well, is there a part of the brain that the seizures are coming from? And if the seizures happen every 3 days, 5 days, then I could bring you into the epilepsy monitoring unit, capture the seizures, and now I'm asking a different question, which is where are the seizures coming from? Because now we're talking about looking into epilepsy surgery and stuff like that. So under those conditions, I'll redo it. So new seizure types, evaluation for epilepsy surgery, check for resolution of certain types of backgrounds that we need to fix. Those are reasons to do repeat EEGs. Because it's 6 months and I like to do an EEG every 6 months because I can get it authorized every 6 months and get a nice payment out of it, for lack of a more delicate term, I don't do that. I don't think that's beneficial. Did I hit most of the points of that question? Okay.
I have 2 actually, be really quick. I just learned from you that you can have a seizure and affect only one side of the brain. So it's possible then for a child to be still playing with the toy during the seizure. Have you ever seen that yourself?
Yes, it's possible with some types of seizures.
Because he does it, and our doctor didn't think. The second question is, do doctors read an EEG differently then? I mean, why do doctors read it differently? Like your interpretation of an EEG, can it be different than another doctor's opinion?
Looking for the delicate answer.
Okay. Yeah, don't be, I think everybody appreciate it, because it's
Most people who read EEGs are well trained in EEGs. And most, if I'm sitting down with my friends from Chalk and my friends from CHLA and we all look at the EEG, we're all going to see the same thing. There are certain doctors that I know where if I get an EEG report from that doctor, I need to either repeat the EEG or order my own. So, I mean,
that answers my question. I mean,
yeah.
that's really good, because it's awesome, because it's like getting a second opinion and going somewhere and getting a second opinion.
Yeah, so most people who read EEGs are well skilled in EEGs, and some people like to believe they're well skilled in EEGs and are not, unfortunately.
Perfect. Thank you.
He had a stroke 4 years ago, and when they hooked up the EEG, because he was put into a bunch of comas, his EEG monitor was black. So it was a stroke, ended up being, we found out later. But is there signs? How would I know if he's having a stroke rather than a seizure? Wouldn't the EEG be an indication of a seizure or a stroke, like in the future, if there's...
I mean, I don't know what the EEG was black refers to. That could be any number of really technical issues.
Possibly, yeah.
Turn the high frequency filter on, 60 hertz filter. I don't know what the EEG turns black means.
What I meant is there's just so many wavelengths, it's
Right.
so close together, basically that's why I said it was black.
Yeah, so a stroke would usually show a loss of function, all right? Right. So whereas a seizure is usually a excessive gain of function, to put it, stroke, you lose ability in one arm. Seizure, you're shaking that one arm. So it's more of a gain versus loss of function. Either way, go to the emergency room and get evaluated. Don't just go, I think it's probably more likely a seizure, unless, if he has seizures regularly, you know what his seizures look like. If it walks like his same seizures, talks like his same seizures, then there's no reason to believe that it's actually a stroke this time.
So there is stroke trauma in the brain, so can you have a stroke during a seizure because of the trauma?
In the United States, it's flipped. Stroke is the #1 cause of epilepsy in adults. So it's usually a stroke that results in seizures. It is almost, I can't say anything's 100%, it is almost unheard of for a seizure to be the cause of the stroke.
Even like a 3-day seizure? Just asking.
I can't give any sort of number on that, but I've yet to see it.
Okay, so a seizure cannot necessarily been studied yet, can cause a stroke.
I have not seen it. Any other questions that I can answer for you guys? No? Okay. Well, they have me in here for about another 6 minutes, so we'll stop here. I'll be up here until they kick me out. So if you have any questions you don't want to ask in front of the group, please feel free to come up and talk with me. Thank you.